So when you do a maximum abduction and maximum adduction, it will tell you where the hinge is. Is it true movement of abduction in the head, or is it a hinge abduction at the edge of the acetabulum? The sphericity of being highest is where you have a younger child with longer remodeling time. So to look at a hinge abduction, you may do an X-ray in abduction and adduction. So what do? I don't get an X-ray done. I take the child under image intensifier and examine the child under image intensifier and see. And when you do this, you can see that little depression which you can see there, it abuts against the edge of the acetabulum. But as it abducts, the medial joint space increases. So in an X-ray, what you see is an increase in medial joint space. So you have this joint space increasing, and that's a clue to a hinge abduction being present and an abduction view of the X-ray of the hip joint. In a dynamic view, you can see it under image intensifier. In a static view, you just look at the joint space and you'll find the hinging that happens here. That's what you have in a patient who is presented to you with a hinge abduction. So once you've seen for hinge abduction, you will find you can plan for surgery based on whether hinge abduction is there, whether there's a good range of abduction or adduction, and then take on. Now just visualize this. If you remember the staging that we had, stage of avascularity, okay, and then stage of fragmentation. Stage 2 was stage of fragmentation, and that is the time when maximum deformation happens. So if you have stage 2B, then there is further fragmentation of the femoral head. Once you reach beyond stage 2B, the head is very collapsed and there is likelihood of hinge abduction. And once hinge abduction is there, doing a surgical intervention will not work of the varus derotation type. It will not work. Therefore, the best stage when you can do a surgical intervention is a child who has not reached the full fragmentation stage, but just before stage B or beginning of stage 2B, and the head is still spherical enough to have a range of abduction and adduction, and the child has extrusion coming on. You want to contain that femoral head. That is when you do a varus osteotomy. So that tells you the indication for doing a varus osteotomy. And remember, greater the extrusion, poorer the prognosis in the child. And once that goes beyond into stage 3AB, the reparative stage is where you have maximum deformation, possibility of hinge abduction, maximum restriction of movement. So it is best to advise surgery before the child reaches this stage. So you have to anticipate a given case of Perthe disease. When he is coming to at this stage 1, that is the time to advise the parents, look, and the child is between 5 and 7 years or 9 years. You tell the parent, look here, this head will progress on to collapse, then fragmentation, then more fragmentation. And that's when deformity of the femoral head happens. Before the stage reaches that stage, you will plan for surgery to contain the head before extrusion, and you will plan for surgery so that you prevent extrusion, keep the head contained. A contained head, even if it is avascular, with the molding of the acetabulum, will grow spherical. So the key to your decision making in your case of Perthe disease is looking at 1, the age of the child, 2, the extent of involvement, 3, what is the stage in the Elizabethtown classification as described by Benjamin Joseph. So those are the criteria which helps you decide. every child will go through extrusion stage from the time of onset somewhere down the progression of the disease. Once you do a proximal femoral varus derotation osteotomy, you bypass the stage of fragmentation in many. It reduces the duration of the disease. It reduces the extent of extrusion. It reduces the duration of fragmentation. It reduces the degree of metaphyseal widening of the neck, and it keeps the head spherical. All are goals in your treatment for Perthe disease. So how do I decide in a given case of Perthe disease? I look at it clinically, look at the child clinically. I know the age of the child. I look at the range of movement. Is there a free range of movement? Though there is a restriction of abduction, it's not a total restriction. There is no clinical evidence of hinge abduction in this child. I look at the X-ray, see the degree of avascularity. If I need to look at bilateral cases there, I'll always get a thyroid function test done and look for other telltale signs of any syndrome or any dysplasia. That's what you have to tell the examiner. I'll exclude in a bilateral case, not so much in a unilateral case. So if it is unilateral, you may consider looking for an MRI, not for this side. If the X-ray is showing changes, the examiner will immediately ask, why do you need an X-ray? It's obvious on the, why do you need an MRI? It's obvious on the X-ray. So the candidate can explain, sir, the opposite hip looks normal on this X-ray, but I want to be sure it is normal. I want to pick it up on an early stage on an MR disease. So I will look at these parameters to decide on what to do in a given case. So I look for the hinge abduction, as I mentioned, by getting an abduction-adduction X-rays, or on the table itself. I don't subject the child to unnecessary radiation. Anyway, when I take the child, decide it for surgery, clinically I'll assess it and decide for surgery, and then take under image intensifier and look at the degree of range of movement. So I get the abduction X-ray like in this child. This is an abduction X-ray I've done. The head is contained in this abduction X-ray. So I can plan for a surgical intervention. So this is what the video again. On the table, you do this and check out. Do I look for the age of the child in decision making? I do look for it, but I still have a little variation because not all of them are protected by the age criteria. Therefore, I'll still follow the child closely. If I think it is extruding out more, I do plan for surgery in a younger age group. With a guarded approach, yes, I will look at the age in deciding. Then I look at the lateral subluxation and then plan for surgery for containment. So you